It's a great opportunity for me as we are meeting online in this period to welcome each and everyone, more so to our teachers, senior, and the office bearer of the Varanasi Surgical Society, Dr. Sudhir, Dr. Kaushik, and his executive team, and our today's webinar moderator, Professor Manoj Pandey, Dr. Sudhir Singh again, and all the three speakers. Dr. Deepak Singh, surgical oncologist, is a very daring, skilled, confident oncosurgeon. Dr. Sujit Verma, a radiologist with a different skill of interventional radiology from SGPGI, and Dr. Ankita, a committed, dedicated oncologist and very good NABH coordinator. Once again, I welcome you all, sir, for a very good webinar. I think we will be sharing the knowledge of interdisciplinary specialty, and we all will be benefited. Thank you very much for giving us the opportunity.
Thank you, sir, for welcome, and we are delighted to have you. Now, I would like to invite the President of Varanasi Research Society, Dr. Sudhir Singh. He is MBBS, MS, in plastic surgery. He did his MBBS and MS.
Respected teachers, seniors, colleagues, and my friends and juniors also, it's my proud privilege and honor to be here with our learned fraternity. It is no doubt that surgery, especially oncosurgery, involving aesthetic reconstruction in the head and neck and breast surgery, have taken a great leap. So is with international radiology, interventional radiology, especially regarding artery embolization in the trauma patients. However, another important tool in management of onco patients is radiation therapy, which has also progressed from conventional to IGMRT, IMRT, and world most advanced VMAT. This important CME has been organized to discuss and update these relatively newer advances for the benefits and understanding of all participants. I thank Apex Superspeciality Hospital, which has forwarded to associate with us to organize this Zoom webinar in coordination with our Varanasi Surgical Society, that is Varanasi chapter of Associations of Surgeons of India. I take the opportunity to welcome whole Apex team, Chairman Dr. S.K. Singh, CME Coordinator Mr. Kamlesh Singh, all speakers, Dr. Deepak, Dr. Sujit, and Dr. Ankita, and all members of our society working behind the scenes. It is again my proud privilege to welcome Professor Manoj Pandey, the renowned oncosurgeon of IMS BHU, and who has been awarded with Top Scientist Award in the world recently. He will be also one of the moderators. Lastly, I welcome all the executive committee members, teachers, seniors, colleagues, juniors who are participating in this webinar. With these words, I end my presidential address and hope this webinar will be enriching and more meaningful to every one of us. Thanks a lot. Thank you.
Thank you very much. A very good evening to all my teachers, my friends, the juniors, and my student. Today's webinar is on three very important subjects. The first topic that is going to be covered is a complex maxillary reconstructions. With the advent of microsurgery, which was, I think, sometime 20-30 years back, Professor M.M. Tripathi has pioneered microsurgery and hand surgery in BHU. But this is something which had been lacking in this city and has not come to the forefront and being utilized in uh, patient management in full capacity as it is being done now. The second topic is interventional radiology. That is again one thing which was not there in the city of Banaras. And now there are two centers which are already doing it. And Banaras Hindu University, IMS BHU, is going to start it very soon. The machine has also already been commissioned in the super specialty block. And the third is radiation. Uh, The Apex Institute has been pioneer in radiotherapy along with BHU, and there were two working like a sister institution catering to the need of Varanasi. And now there are two more institutions, and with number of machines increasing, and slowly this Banaras city is becoming a medical hub. And this is something which is very important for all of us, that with this city becoming a medical hub, there is more role that every surgeon, every physician, every oncologist has to play in management of patients. This is not only limited to the institutional practice, but it is also limited, it's also to the private practice, because there are more number of people coming out and joining private practice. And this is going to put a kind of a pressure on my colleagues in private to deliver quality results. And this is what we are going to see, and we are seeing it, that the face of the private services and the institutional services is changing. So without wasting any more time, I'll request our president, Dr. Sudhir Singh, to start the today's proceeding and invite the first speaker.
Thanks a lot. I hereby invite Dr. Deepak Kumar Singh, consultant surgical oncologist, Apex Hospital, Varanasi. Um, he's, he has a special interest in cancers in women, reduction of treatment, toxicities, organ preservation, and minimally invasive surgery. Innovation, disposable customized aerosol containment chamber for biopsy during COVID pandemic. He has published one paper, I think, when he was here as assistant professor in the Tata in Varanasi, along with Sudhir Singh. I remember that. Then he has also multiple international national publications, oral and abstract presentations in international conference, reviewer for more than 15 international journals. And I have also an experience working with him recently when we did a microsurgical reconstruction of the face with the ALT flap, free mask, just recently, a month back. Okay, I invite you to carry on your talk.
Hello, good evening, everyone. Am I audible?
Yeah, you're audible.
Yeah, yeah. Thank you, sir. So, good evening, everyone. Respected President, sir, respected Chairperson, and respected moderators, and most of all, to all my seniors and teachers whom I see here. And I'm very indebted that it's because of you that I've come back to Varanasi. And it feels like a family to be here. So today we'll discuss about the breast and head neck cancer surgeries and the aesthetic and complex reconstruction that we do or we aspire to do in these particular two cancer scenarios. We'll start with the breast cancer reconstruction and aesthetics. So before we venture into any surgery, I would like to bring about the new concept of the breast self-awareness that have that has been always there. So it's completely different concept from the breast self-examination. It's basically a awareness of the woman regarding their breast and their appearance. So it's like the what is the normal for their breast, whether it's small or big. So what they have to do is do nothing but just notice the change in the size, shape, appearance, texture, or any color, any irritation, any skin changes in routine, which is not subject to that particular time of menstruation. So if we bring this self-awareness among the female and the ladies that we see around us, our colleagues, our servants, or maybe our family members, then maybe we can have patients who come to us with early with presentation of a early breast cancer instead of the locally advanced one that we see normally. So we'll start with the concept of the personalized care in breast. So initially, when we used to learn with our professors, they used to offer different treatment for its similar stage of disease to different patients. And we often used to wonder that why Professor H.S. Shukla, why Professor Manoj Pandey is offering a different treatment to different patients with the similar stages. So the thing was, they were offering a sort of personalized care in which they used to see about the social aspect of the patient, how they live at home, whether they come from a good background or a very poor background, whether they'll come for follow up or not, where they are keen on treatment, they want a single sitting treatment or they want a multiple sittings, or they can stay in the city or they cannot stay in the city. So they used to offer a sort of personalized care to the patient. Then came up the concept of art training, where we used to go by the guidelines, where we used to treat the patient by stage alone. Now again as we grow up and we again learn, so what we now learn is the personalized care. This is the same care that a professor used, like Professor Anand Kumar sir and Professor Manoj Pandey sir used to offer to the patients, which we learned 20 or 15 years back. So it's a old concept revisited again and again with changing time. So we'll start with a lady. She was a 25-year unmarried lady who came to us with a large lesion, who just decreased to a size of 2.6 by 1.5 centimeter in the upper outer quadrant after giving neoadjuvant chemotherapy in a triple positive grade 3 IDC cancer. We did a mammogram and a MRI because she was very keen on conservation, and she wanted a BCS because she was unmarried. So the MRI showed a architectural distortion with a adjacent solid nodule of 1.4 centimeter and another 6 o'clock intramammary node, which they commented to be a myxoid fibroadenoma, and a third lesion which was palpable pre-chemotherapy also. That was a 2 o'clock upper inner quadrant fibroadenoma. So here we see the PET scan. This is the pre-chemo PET scan where we see the primary lesion, adjacent nodule, and the fibroadenoma without any uptake. So we offered this lady a wire localized excision of the all three lumps. The wide excision was done for these cancerous lumps and just a simple wire localized excision for the fibroadenoma and the tubular adenoma. These are the three histologies post chemotherapy and post surgery, and these were margin negative. So now we'll come to the next concept, that is the concept of oncoplasty. We'll try to jump into the concepts because the time is very short, and we'd like to chip in all the different varieties of armamentarium and the surgical issues that we face and the surgeries that we offer to the patients of breast and head neck. So oncoplasty is nothing but the cancer surgery done and a plastic surgery planning and surgery done in the same sitting, as the name suggests, oncoplasty. So the benefits of the oncoplasty for the patient is that when you know that you'll reconstruct the breast, or a plastic surgeon will reconstruct the breast, you will not shy away from removing adequate margins. When I say adequate margins, it means a ink free of any tumor, and for radiation it's less than more than 1 mm. So so the volume displacement or the replacement is the basis of oncoplasty. If the excision is very small and the breast is adequate size, we can do away with only displacement alone, or we have to replace the tissue if the we have removed a very large chunk of the breast because of the large tumor size, or the breast per se is very small. So it's of different types. That is the immediate reconstruction, which is done in the same sitting, which allows for a wider local tumor excision I already described. But if you have a complication after the immediate surgery, that is a single sitting surgery, the adjuvant treatment of the patient might get delayed. So this is not a primary treatment modality for many surgeons. They practice what is the delayed, where they do the surgery after many months or years when the patient has completed the adjuvant treatment of both radiation and chemotherapy. When we say delayed, that means the primary surgery has already been done either before chemotherapy or upfront after chemotherapy. This has been told to have a higher complication rates because the residual breast has already received radiation, and you have to operate on a irradiated breast which has a decreased vascularity. So these are the different volume displacement techniques where do not bring any more extra tissue outside the breast or from surrounding area, and the same breast tissue is used to give a contour and the shape of the shape to the breast. So we do a different techniques for the different quadrants. For upper outer quadrants, we do a lateral mammoplasty, as you can see here, and we undermine the NAC after removing the skin or the epidermis, so that you get a centrally placed nipple areola complex, and it does not get displaced because of the tumor that you've already removed. And to do a J plasty or a L plasty, which you'll see in subsequent photographs, which I'll show, and you do a repositioning for the nipple, and you do inferior mammary fold plasty. You can do for the inferior lesions, where you create a new inframammary crease after removing a linear transverse and rim of tissue along with the tumor. The other thing that you can do is the for the middle quadrants, the upper and lower are the omega mammoplasty, or a different kind, that is the bat wing mammoplasty, either a double wing or a single wing, or else you can do a vertical mammoplasty or inverted T mammoplasty for the inferior quadrant.
It's a request to all to kindly mute your microphones except Deepak Singh so that we can all hear him.
Thank you so much, sir.
Deepak, continue. Continue.
Now we'll discuss about the volume replacement. So in volume replacement, we use different tissue either in the immediate vicinity of the operated area or from a distant site. The volume replacement can either be in the form of latissimus dorsi flap or a mini LD flap, as we call, or the anterior intercostal artery perforator flap for the medial inner quadrant or the inferior outer quadrant lesions. Then the local flaps are the lateral intercostal artery perforator flap that we use for the upper outer quadrant and sometimes even the central quadrant if the breast is small, and a thoracodorsal artery perforator flap where we will dissect the latissimus dorsi muscle and remove the subcutaneous tissue and dermis and epidermis for repositioning. Or we can use local rotation flaps like thoracoepigastric flaps. Now we'll come to what we can do after we have removed the whole breast for the patients. Then also we have different options, and some patients are very keen after treatment completion to get the normal contour, which can be offered either in the form of a pedicle tramp that even oncosurgeons do routinely, or you can do free flaps in the form of superior gluteal artery perforator flap if you have adequate bulk in the upper outer quadrant of your gluteal region, or the inferior gluteal artery perforator flaps. Now we'll visit into some specific cases. Here we see a lady who has come for upfront breast conservation, having 2 tumor nodules with biopsy-proven cancer. We did a sort of inverted V excision of the inner quadrant, and we rotate the lateral breast after undermining. And this axillary incision was used for the dissection, that is the axillary lymph node dissection of the left side. This is another lady whom we use a Weiss pattern or the inverted T that I had already described, and we create a new inframammary crease by rotating both the medial and lateral pedicles of the breast. This is the third patient wherein we have used the thoracodorsal artery perforator flap. This lady received chemotherapy because she had some skin changes also, which we can still appreciate here. We did a wide local excision of the lump, including the overlying skin by taking adequate margins. A specimen mammogram was done, and this was found to be adequate, and you can see the labeling of the specimen before sending for HPR. And now we had harvested a flap of around 15 to 7 centimeter, and we used the skin paddle, and the rest was deepithelialized. This was then inset using a tunnel of the lateral breast using as a tunnel, and we used the appropriate size of the skin. The overcorrection, which you can see here, because the lady had A cup size breast, has been done because there will be some radiotherapy to these left breast. Hello. Now we'll come to the other flap that we have done, that is the lateral intercostal artery perforator flap. So here we can see that we have used the anterior skin for the undermining on raising the flap for the skin of the breast, so that we can remove the tumor that is here, which was 1.5 to 1.8 centimeter away from the skin. So we could achieve adequate margins by just undermining the skin and remove the tumor, which has been labeled as black anterior and short and long, superior and lateral respectively. So one thing you can notice that this lady had a smaller size breast on the left side even before she had the tumor, that was pre-therapy, and she had a similar contouring post surgery also, and you can see a single scar which that was the breast surgery, the axillary surgery, and the harvesting the LICA flap also. Yeah. Hello. So now we'll come into the beginner's guide. Beginner's guide means because when you start doing this oncoplasty, you should always see to that you should not start with the ptotic, large or elderly females, because then you'll have more chances of fat necrosis, flap failure, or any thrombotic events in case of multiple morbidities like diabetes and all. So you should always start with a small to moderate size breast, that is around A to C cup size, which is easier to start with, and they have better results and outcomes post radiotherapy also. So for a general layout, if you have removed a very small chunk that is less than 50 gram, so you can actually do a purse string of the NEC complex that I've already shown in the first slide, or you can do a proper linear suturing of the defect, and then you can have a seroma formation that will take care of the contouring of the breast. If the defect size is slightly more, or you have removed around more than 10 to 20% of the breast volume, then you can use the adipofacial flap or the ICAP or the TDAF flap or the LICAP flap that I've already showed in the previous slides. If you have a much larger defects, but still you have half or more than half of the breast tissue left, then you can use the latissimus dorsi flap to fill the defect, or you can use a LD flap with a processes. So now there are these are the very common scenario that we see in India. You can have patients who had slow growing tumors of breast without any metastasis and they come to us, or you can have a bleeding fungating masses like this. So when you remove them with adequate margins, what you have is a very big defect in the chest wall, which can be easily reposited by using local large rotation flaps that we see here that has been done, and this can be easily done in a single sitting without much problems of margin necrosis or flap failure. And here is a similar second patient where we have done a little slightly tightly closure, and a T-shaped closure of the axilla has been done to decrease the tension on the medial sutures. So now we'll come to the next portion of our talk, that is the dealing with the head and neck cancers in in our day-to-day practice. So what are the different problems that the head and neck cancer patients come? They come with disfiguration, both pre-op and post-op, the dysfunction that they'll have post-op, the deformity that they face lifelong now after having cancer, or the depression that goes along with it, which can be easily seen in this photograph. So the resection, as I still remember Professor Manoj Pandey, anything that is not attached to the table can be removed by an oncosurgeon. So resection is no more a challenge, but what matters is the reconstruction, for which we are very thankful to our reconstructive team and plastic surgeons which we have, and who help us to do any sort of resection that we plan to. So we'll start with the local small flaps that we routinely do inadvertently, that is the buccal advancement flap that we routinely do for the upper lip and the lower lip lesions after the wide local excision of these lesions. So here you can see a buccal fat pad which we routinely do, and first time I learned in BHU only before I went to TMH. Here you can see a small defect being created in the buccal mucosa, which has been easily being replaced by putting some tacking sutures in the buccal fat pad. The another flap that we less commonly use done by plastic surgeons is the axial frontonasal flap or the rotation flap. It's a very big rotation flap for the basal cell carcinomas of the tip of the nose, wherein this whole flap is rotated and sutured here, and this inverted V is closed primarily in an inverted T fashion. And next is the palatal island flap, which you do for oriental fistula or some localized lesions near the tonsillar pillar or near RMT based on the. Now next comes the forehead flap, which we most commonly do. It's a interpolation flap because there is a normal intervening tissue between the recipient site and the donor site. The only thing or the only caveat to be think is that the donor site should always be replaced with if split thickness unmeshed graft. When you do a meshing, you might have a granulation inside these meshing areas which are not seen here, and you might have an unsightly scar. So it's preferable to do a unmeshed split skin graft. However, this graft is not this flap is not very commonly done for ladies. It's a last resort flap and a very good uh, yeah. Next we come to the facial artery musculomucosal flap, that is the FAM flap, which is either in the form of superior FAM flap or inferior FAM flap. Superior flap can be used to cover the hard palate or the superior alveolar crest defects more commonly. It can even reach up to the skull base or the orbit or the maxillary antrum. The flap is around 2 to 2.5 centimeter in width, and it can be slightly long, around 7 to 10 centimeters also. The inferior fan flap can also be raised on the based on the same facial artery, and it is used to cover the lower alveolar crust, the inferior lip, or the mobile tongue, or even the floor of mouth. Next is the Abbey and the Accelerator flap, which we most commonly do in our local OTs in BHU, in minor OTs on our weekdays. So the one is the Abbey flap, that is then for the lesions that are placed in the mid or slightly lateral position in the lip. And when you have the defect close to the commissure or at the commissure, you do a rotation sort of flap, that is the Accelerator flap, based on the superior or the inferior label artery based on the donor side. Next is the tongue flap or the interpolation tongue flap, which are either anteriorly placed or posteriorly based on the base of the pedicle of the flap, and these are also raised in the ratio of 3:1 of the length and breadth. So it can be used to for the defects of buccal mucosa laterally and even the RMT lesions. Next is the most common used flap or the nasolabial flap, which it is also interpolation flap, and the indications are 2 to 3 centimeter inside the oral cavity, either in the lip or in the tongue or the floor of mouth or the buccal mucosa. All can be used. We can even use bilateral flap for some median defects, which are around 5 centimeter size also. However, there are some complications like congestion, hematoma, ischemia, and necrosis, or cheek biting because of bulky flaps. And this needs a two-stage procedure that we do routinely. Nowadays, few people do a islanded one, which is a single-stage procedure where you dissect whole of the facial artery up till the lower border of the angle of the mandible. So here we can see the reposited and closed using a right nasolabial flap, superiorly based. This is a defect, large defect, which we can see, and which has been closed using a bilateral nasolabial flap. Next is the sternocleidomastoid flap. I don't do it routinely, but Sir does it very routinely, and I think he has umpteen publications on that. So maybe Sir can tell us more about it after in the discussion phase. So you can raise it either in the form of muscle alone for different defects of the pharynx or the tracheostomy defects, or the oral defects, or even the pharyngeal defects, or you can raise it with a skin with muscle based on the superior thyroid artery. And some people have also reported to raise it with muscle with clavicle, that is the inferior part which goes and attached to the clavicle. Next is the submental flap. So submental flap can only be raised in cases of carcinoma, wherein it is node negative, very small lesion, well differentiated, where you're very sure that the neck nodes are negative, or else you should refrain from using a submental flap for a node positive neck, because you tend to leave the 1A nodes if you harvest a submental flap. And next we come to the armamentarium of the pedicled myocutaneous flaps. Here when we most commonly used are the pedicled cutaneous or faciocutaneous flaps. These are the deltopectoral flap, the temporalis flap, the pectoralis major myocutaneous flap, or the trapezius myocutaneous flap, or sometimes the platysma flap. So here you can see a bite composite resection being done of the left side, followed by reconstruction using a single paddle for the inner buccal mucosa lining, PMMC flap. So next we come to the free flaps, which can be either be myocutaneous or osteocutaneous or osteomyocutaneous in the form of anterolateral thigh free flap, a radial forearm free flap, or median sural artery perforator flap, or a fibula free flap. So the radial artery forearm free flap is a very commonly done flap for small defects because it has a very pliable skin. The only thing is to be taken care because it has two anastomosis of the vein of the vena comitatus, which we'll discuss later on. So you can see this after hemiglossectomy, we have seen the FRAF defect, and these two patients now can speak very well in the post-op, and they have a near complete or near normal function of the tongue post-surgery. This is the free fibula flap or the osteomyocutaneous flap that we have done for the right segmental mandibulectomy, and we have fixed the fibula bone with the screws. The fibula bone can also be used for the osseointegrated implants or the tooth that can be implanted later on to the patient. Next is the anterolateral thigh flap, which we can use here for a lip commissure lesion, which is being used. It offers a very large pliable skin for very large defects, both in the inner buccal mucosa lining and the outer skin defects also. Here we see a different patient who had a completely near total bite composite resection followed by a anatomic thigh flap done because the radial artery was too small for this defect. Next is the middle sural artery perforator flap, which is being very commonly done by Dr. Gautam here in Varanasi. So it is a very precarious flap, but he has done a few cases now which he published. So this also we use slightly seldom, not that commonly, for defects. So this is a left marginal mandibulectomy with wide extension of the buccal mucosa neck dissection, which has been replaced or the defect closed by using a middle sural artery perforator flap. So but the main goals of head neck reconstruction that the patient should be free from disease. When you get somebody else to reconstruct for you or short on margins or shy away from taking adequate margins, which is a very common prognostic and very important prognostic indicator, both for the adjuvant treatment also in the form of CTRT for closed margins and for prognosis or the overall survival of the patient. So you make the patient free from disease by removing adequate margins, and you get a physiological well-functioning residual function of the tongue or the buccal mucosa or the oral cavity or a good wide mouth opening. The patient is socially active because the cosmesis is good, and he's professionally competent because he can go about after having the surgery and treatment completion. So only thing before I finish my talk is that a very well done pectoralis major myocutaneous flap after the muscle has atrophied has a similar results or maybe even better results both in the immediate post-op and the late post-op with decreased complications. So we should never shy away from using the PMC flap just because we want to shun the responsibility to the plastic surgeon, because a very well done PMC flap lasts long. They have now very few complications, very robust flap. And when you see those flap after a few years of follow-up, they don't have any difference either in the function or cosmesis as compared to the free flaps. So again, reiterating the fact or the team effort of the our team, that is radiation oncologist, surgical oncologist, medical oncologist, the intervention radiologist, histopathologist, and our physiotherapist also, and rehabilitation expert that we have in Apex. I would like to tell that individually we are just one drop and together we are one ocean. So thank you everyone, especially my teachers, for giving me this opportunity for delivering this talk. Thank you everyone.
Which is a good thing to do during the talk. Dr. Sudhir, would like to say something?
It was an excellent presentation by Dr. Deepak. I congratulate him. He has covered almost everything about plastic surgery, along with his onco surgery. It's a great one of the best presentation. Do you find any questions asked by the public? No.
Deepak, can I ask?
Yeah, you can ask. Who wants to ask can ask. Hello.
I'm Dr. Ajay Khanna.
Yes, sir.
Can you listen me?
Yeah.
Yes, good evening, sir. You're audible, sir. You can go ahead, sir.
Right. Deepak, you made a very good presentation in a very short time of the two vast things which were there, breast as well as the head and neck. Now, I just wanted to know that in your one last case of the advanced breast cancer, where you make a big rotational flap, why did you put 3 tubes there? Just a query,
So that flap was done. So that flap was done by my team. I was not in that case. But most probably it might be because of the large that tunneling the effect that we have because of raising large flap. So they might be anticipating seroma or maybe post-operative high drain. That's why they might have done that.
Now, can you tell that if there's a Phyllodes tumor is there, then what is the way to have the best reconstruction in a young girl of about, say, 25, 30 years, where almost you are going for almost a total mastectomy? What is the best way of reconstruction of that?
Yes, a total mastectomy. Yeah. Yes, sir. Sir, I would like to offer that lady a free flap in the form of a deep inferior epigastric free flap or a superior gluteal artery free flap if there is adequate bulk in her gluteal tissues.
Okay.
So that will refer to my plastic surgeon. I would not like to do a tram that we do routinely, which without a plastic surgeon, because then she'll have some defects.
Now, you made a quote of Dr. Manoj Pandey that he used to say that if anything is stuck to the table only, that cannot be removed, everything can be removed. But this, I think Dr. Manoj Pandey
That
will
was
agree
to
with
boost our
that.
confidence, I think.
Yeah, that's right. No, but this particular thing was given by Dr. D'Souza. I think Dr. Manoj Pandey will remember that. Dr. D'Souza from the Tata Memorial, I heard him in my student days, he used to say this word, that if anything is fixed to the table only, then that cannot be removed. Rest everything can be removed. But you know what is the outcome of that? Easy to say that, but what is the outcome? You know it very well. No, do you have any idea about the indocyanine green which is used nowadays for the flap surgery? Have you ever used that indocyanine green?
Yes, sir. People are using it for No, sir, we have not used. We have tried. Tata has just procured a fluorescence camera, so they'll start using ICG in, I think, thoracic internal memory nodes in Mumbai, and for, I think, axillary sampling, that is the sentinel lymph node biopsy also in some coming months.
No, but indocyanine green for
But I have not used it personally,
for the flap surgery, I am asking. If you are raising the big
flap surgery, sir, you can actually. I have not used it for the flap surgery. No, sir, never.
No, the last flap which is showed the sural artery flap which is there. Is it a neurosensitive flap?
So it can be made a neurosensitive flap also, but the flap which Dr. Gautam does are not neurosensitive.
Mm-hmm. And I think probably you have rightly said that to a general surgeon, he should know at least one or two flaps, and one of the most important flap he should know is the pectoral myocutaneous flap.
Yes, sir. Yes, sir.
Thank you. Good presentation.
Thank you, sir. Thank you, sir. Nice meeting you again.
Dr. Deepak, it was an excellent presentation. We liked it. And actually, the most important flap, if we have to know, is ALT flap. We cover most of the microsurgery part. The second is the radial artery forearm flap and fibula flap. We cover almost everything. And about the medial sural, this medial sural artery flap, this is a perforator flap. We go deep into the muscle plane, and then the popliteal that branch we set out. We don't take the nerve in with it. We just do that flap. This was very common in Taiwan when I was training. It's a very commonest. Actually, the microsurgery.
Our own reconstruction. I started my surgical oncology in '96, even before it was recognized by MCI. And we used to do our own flaps. We didn't had the backup of good plastic surgery team. We had been doing it till last year. But at present, most of our reconstructions are done by Dr. Gautam. Because now we have Dr. Gautam joining BHU in plastic surgery, and he is doing most of the reconstructions. So I don't think to become a general surgeon or an oncosurgeon, you need to know the flaps.
Verma, he's MD radio diagnosis, PDCC Neuro Radiology. He's a consultant interventional radiologist at Apex Superspeciality Hospital, Varanasi. Experience in the field of interventional radiology. His work is on vascular intervention, GI and renal bleed embolization, and stenting, carotid stenting, diagnostic cranial and therapeutic spinal embolization, trauma, peripheral vascular intervention, emergency vascular interventions, non-vascular interventions, specialist in CT and USG guided FNA biopsies. First, he also got first prize in spotting session at Lucknow's chapter held in KGMU, presented paper and poster IRIA conference and CME, 2 case report published in EuroRad. He will be speaking on the role of interventional radiology in trauma. So now it is to Dr. Sujit Kumar Verma. He will be presenting his talk.
There is no audio.
Am I audible?
I am audible, fully.
I am audible?
Yes, Dr. Sujit,
Yes.
we can hear you now.
Thank you, sir. And good evening, everyone. Today, I am going to discuss briefly about the role of intervention radiology in trauma and few cases we have we have successfully done at the Apex Superspeciality Hospital. As we all know, trauma continues to be the leading cause of mortality in young population. Uncontrolled bleeding is the most common cause of early trauma-related mortality. Over the past 2 decades, there has been paradigm shift in the management of traumatic injury with inception of the concept of non-operative management, which is followed if there is no sign of no peritoneal site or hollow viscous injury. Intervention radiology is an extension of non-operative management, which not only save life by achieving the hemostasis at the site of vascular injury or difficult access surgical site, but it also controls rebleeding following. In current scenario, in vascular injury, intervention radiology can obviate emergency laparotomy not only in hemodynamically stable, but also in unstable patient as well, as evidenced by the recent literature. Intervention must meet the following criteria to be an effective player in the team management of trauma patient. And a skilled IR who is available for consultation on urgent notice, availability of high quality digital subsection angiographic equipment, availability of skilled nursing and equipment needed for the monitoring of critically ill patient, ability to ready these resources within 30 to 60 minutes. Equally important is the treatment of trauma patient require efficient use of these resources as well as cooperation and communication among a multidisciplinary team. So, interconventional treatment modality which are commonly used in trauma includes the first balloon occlusion, inflation of an angioplasty balloon proximal to or at the major arterial injury may temporarily stop or reduce the life-threatening hemorrhage and thereby stabilizing the patient while definitive surgical or endovascular repair is being arranged. Second includes the transarterial embolization. It can stop the arterial hemorrhage, thus improving the unstable hemodynamics and often avoiding the need for surgery. Prompt, effective, and safe transarterial embolization requires skill and knowledge of the available equipment, arterial anatomy, role of collateral arterial flow, and risk. A variety of catheter, including proaxial microcatheter, available, selective catheterization to visually all arterial circulation. Embolic agent vary in their permanency and anticipated level of arterial occlusion. The choice of embolic agent will vary based on the site and nature of the injury, the desire to preserve the collateral flow, and operator preference. The gel foam, particle, and coils are some of the most commonly selected embolic agent in trauma. Care must be taken to avoid non-targeted embolization. Third include the stent graft. These are increasingly being applied in the treatment of large vessel injuries and may enable one to avoid complex surgical vascular repair in areas with trauma-related anatomical distortion and in patients who may be unstable. These considerations must be weighed against the long-term sequelae of the device implantation, which are largely unknown. This case was taken from an article just to show the placement of stent graft. Here, the first image, which is showing that there is the check angiogram, which shows the pseudoaneurysm of the femoral artery, superficial femoral artery, and in this image, we can see the placement of the stent graft, and after placing the stent graft, we can see clearly the reconvolution of the channel. And these are the follow-up image of the stent graft. Then we come briefly about the discuss what complication can occur during the intervention radiology procedures. The complication after the endovascular intervention include the puncture site hematoma, pseudoaneurysm, retroperitoneal hematoma, which rarely occurs, and arteriovenous fistula, arterial dissection, distal embolization of atherosclerotic debris, AL, arterial thrombosis, and non-targeted embolization. The risk factor for the excess site injury include the use of larger excess site, the site of arteriotomy, previous catheterization at that site, smaller body mass index, coagulopathy, female gender, antiplatelet therapy, and uncontrolled hypertension. So now comes to the few cases which we have managed at the Apex Superspeciality. This one, the first case, the case of 21-year-old male patient who got an accident 3 months back with left lower limb injury. Patient presented with the pain and swelling in left lower limb along with the left lower limb immobilization. The X-ray shows fracture of distal femur and fibula. The CT angio reveals the pseudoaneurysm of posterior tibial artery with soft tissue swelling in left distal thigh and proximal leg. Reduction of the fracture was done outside. Attempts were also taken to repair the vascular injury, but it was unsuccessful. When patient came to the Apex Hospital, he presented was with a recurrent history of recurrent bleeding with progressive swelling of the leg. At the time of admission, the patient was stable. However, his hemoglobin was 3.8. These are the X-ray of the patient. Just shows the distal fracture of distal femur, and the intramedullary nail shows suggest the post-operative status. This is the CT angio image of the patient, which we have get. Here we can see the large pseudoaneurysm arising from the posterior tibial artery. Because whenever patient started mobilizing his leg, this pseudoaneurysm got ruptured and patient developed a swelling. This is a continuous progressive swelling. This cycle occurs vigorously, so the patient was having fear of mobilizing his limb. And these are the MIP images of the CT angio to clearly see delineate the pseudoaneurysm that was arising from the posterior tibial artery. After these investigations, we have planned for the embolization of the posterior tibial artery. This is my check angiogram taken from the ipsilateral left femoral artery. Here we can see there is a loss of normal blood vessel. Here we can see the multiple collaterals are filling the distal vessels. This was the next angiogram, which was taken slowly to delineate the pseudoaneurysm. Here we can see the pseudoaneurysm is progressively filling. This was the another check angiogram to calibrate the size of the pseudoaneurysm. But during this check angiogram, the pseudoaneurysm get ruptured and the bleeding was started. But fortunately, we are at the site of the pseudoaneurysm, so we just immediately started the coiling. And these are the post-embolization images. So in this angiogram, we can see the complete embolization of the pseudoaneurysm and good distal flow. These are the pre and post embolization image. We can see the multiple collaterals are filling the distal vessels. These are the embolization just after the embolization. Here we can see this is the site of embolization where multiple coils were placed, and this is the anterior tibial artery which is filling. This is check angiogram was taken to show the distal filling, distal collateral filling of the posterior tibial artery. Post-embolization patient hematocrit was raised and he was able to move his limb without fear of bleed, and patient was discharged third day. The second case was the 45-year-old male patient who come across the road traffic accident with the history of polytrauma and abdominal injury. The patient complains about the abdominal pain and increasing abdominal gas. The general condition was stable, but with time progression, fall in blood pressure and hemoglobin was noted. Ultrasound abdomen shows splenic laceration with grade 4-5 injury and hemoperitoneum. The CT angio also revealed the splenic laceration with grade 4-5 injury and hemoperitoneum. However, on angiographic history, there was no obvious site of no obvious extravasation of contrast, which suggests the arterial bleed was noted. This is the CT angio image of the patient. However, this image is slightly taken in delayed, so there is mixing of the arterial and venous phase, but we can see the hemoperitoneum as well as splenic laceration here. So even after seeing these images, even after the 4 PIVC, patient condition was not improved. So patient was planned for the prophylactic splenic artery embolization. The splenic artery embolization was done with the help of gel foam, but that is the temporary embolic agent. Here we can see, this was the last image where we can see clearly non-opacification of the splenic parenchyma and complete cut off of the splenic artery distal. The post-embolization patient general condition was improved and no further PRBC transfusion was needed. In follow-up, patient developed left dual effusion which was managed and patient was discharged 10 days after the hospital stay. Till that patient is in follow-up with no fresh complaint. A few about points for the splenic arterial embolization. Splenic arterial embolization can increase the success rate of non-operative management by stopping ongoing bleeding and by preventing the delayed rupture of spleen. When the following CT imaging findings are present, if there is a contrast extravasation, pseudoaneurysm, or arteriovenous fistula, large hemoperitoneum, or high-grade injury. The use of gelatin spot has added the advantage of significantly shorter procedure and fluoroscopic time. The third case is of not actually trauma, but it's a case of a 21-year-old male patient who presented with a complaint of recurrent hematuria following the pyelolithotomy for left renal calculus that was done outside. And the patient come to us with when patient come to us, he present complaints about the recurrent hematuria. Patient general condition was good, but his hemoglobin was 7.4. The USG abdomen shows the pseudoaneurysm of the pseudoaneurysm at mid pole of the left kidney. So after these findings, we have planned for the renal artery embolization. This is the pre-embolization check angio, in which we can see the pseudoaneurysm that is filling from the mid pole artery. So this embolization was done with the help of blue, and these were images were taken after the embolization. Here we can see clearly the complete embolization of the pseudoaneurysm and normal opacification of the normal renal parenchyma. These are the blue cast which are shining bright. So after embolization, patient was stable and his general condition was good. Patient was discharged 3rd day after the admission. These are the pre and post embolization images. These are the images were taken at the time of discharge of the patient. So in conclusion, the interventional radiology has much to offer in the evaluation and treatment of traumatic injury. The current literature suggests that this role may expand in time due to desire of organ preservation and avoidance of surgery, as well as due to improvement in the transcatheter equipment. A solid understanding of benefit and risk of different transcatheter therapies is required to provide patient with the best care possible. Thank you.
Thank you, Dr. Sudhir. This was a very short and a very nice presentation elucidating the role of angioembolization in trauma and non-traumatic pseudoaneurysms. The topic is open for discussion.
In a good presentation. Just wanted to know that your patient of the splenic injury which was there, did he develop the splenic infarct or the splenic abscess after your treatment?
No,
So
sir.
that is the commonest outcome.
Yes, sir. Yes, sir. We are also feeling about that, but luckily that patient was not affected this type of complication. But he was developing pleural effusion left-sided, and apart from that pleural effusion, no other complication was seen in that patient.
Okay. And your patient who had a pseudoaneurysm of the renal artery after the pyelolithotomy, can you tell
Yes,
that how it would have happened here? That after the pyelolithotomy there was a pseudoaneurysm formation?
just not detail of the pathophysiology of it, but as the patient was referred our neurosurgeon Dr. PK Casey sir, which take the proper history, and he told about that patient about to me, and just I'm not knowing about the detail of that surgery and its complications.
Okay, just for my knowledge, I wanted to know that, are you doing the stenting for the peripheral arterial disease?
Just we have for the proximal for SFA, but not at this center, sir. But we have in HCPCI, we have done the for the stenting for the pseudonism of the superficial femoral arteries.
Mhm. Sclerotic block is there, or rarely the Burgess is there.
As far as my knowledge, sir, for the below knee peripheral vascular disease, the role of interventional radiology is limited for arterial disease, sir. Actually, even my knowledge, sir, there is a not very good result even after stenting for the below knees arterial diseases.
No, like if there is a superficial femoral artery, localized stenosis is there.
Yes, sir.
Have you any
In that case,
experience of?
that was followed by the proximal embolization with the help of coils.
So it was very nice presentation. I think we can move to the other speaker. I hand over to Dr. Manoj Pandey to moderate the last session.
Thank you, sir.
Thank you, Sudhir boss. The next speaker is Dr. Ankita Patel. And Ankita is a very committed oncologist, a radiation oncologist who has been practicing. And she has a lot of awards, recognitions. And she has got 3 publications and many CME papers that she has presented. She has been facilitated by IMA, by BC Roy Memorial Award. She has been facilitated by Lions Club Varanasi. She also got the Presidential Award by IMA. And even for cancer awareness, she has been awarded by the Rotary Club Varanasi. I invite Dr. Ankita Patel to deliver her talk.
Thank you, sir, for your kind words. First of all, I would like to thank VSS and Dr. Sudhir sir, Dr. Avdesh Kaushik sir, Professor Manoj Pandey sir, Professor Anand sir, Professor Ajay Khanna sir, all the dignitaries attending this webinar and all the attendees. I would like to thank for allowing us to organize this webinar and sparing your time on the Saturday evening for the presentations. So I will be basically speaking about the role of radiotherapy in management of breast malignancies, both early breast and locally advanced. So the roadmap of my presentation will be the radiation after BCS, radiation in elderly, after mastectomy, hypofractionation, fast trial, accelerated partial breast irradiation, intensity modulated proton therapy, and a few words about reconstruction, and followed by rehabilitation. And I will be basically putting up the points which are clinically are of clinical significance, because the topics are many and I need to cover it in 20 minutes. So the breast cancer, everybody knows, is a systemic disease and it needs local regional control and prevent and get rid of the microdistant metastasis. So there is a close-knit association between a surgical oncologist, a radiation oncologist, medical oncologist, and So the addition of radiotherapy to surgery resulted in an improved rate of local recurrence by 2/3 to as compared to surgery alone. And the radiation contributes to the overall improvement in overall survival when combined with the systemic therapy, basically by controlling the local disease. Now, there is an integration of RT with surgery and systemic treatment, and it has made RT more effective. And post-mastectomy radiation in high-risk disease has improved local regional control. And combining BCS and breast radiotherapy is an alternative to mastectomy. So how does the radiation works? Whenever the DNA of any cell is exposed to radiation, it gets damaged. But if it is a tumor tissue, it doesn't has capability to get repaired. So it dies because of apoptosis. Whereas the normal cell, they have the capability to repair, they get repaired and thus survive. So this is the basic concept of killing of cells by radiation. Post surgery, there are certain targets which we need to irradiate to reduce the risk of recurrence. The targets are most in case of breast conservation surgery, the breast, followed by boost, and the regional lymph nodes. The regional lymph nodes are basically axillary level 1, 2, 3, SCF, intraclavicular lymph node, and internal memory lymph node. So after breast conservation surgery, mastectomy is no longer a standard of care in breast cancer surgery, especially in early stage. BCS is possible in all EBC and is also practiced in LABC. Whole breast radiotherapy is compulsory in BCT. And result of BCT plus RT and mastectomy are equivalent, and local control rates are also significantly improved by use of boost to the tumor bed. So this is the entire guideline in a gist. Any breast conservation surgery should undergo adjuvant radiotherapy for all the patients, except there is a very small subset of patients where we can think of omitting adjuvant radiotherapy. The patients are basically very elderly with comorbidities, N0 patients, stage 1 ER positive patients who are convinced to take tamoxifen for 5 years. So radiotherapy to BCS, there is significant difference in local recurrence, both in node negative and node positive patient. And also there is a significant difference improvement in breast cancer mortality, approximately 5.1% in node negative and 7.1% in node positive patients. So once the patient comes, BCS has been done, radiotherapy is done, followed by we need to boost the target, basically the tumor volume we need to boost to improve the efficacy. So this was a trial, and it was shown that after like giving 10 to 16 gray post whole breast radiotherapy has better control rates. So the rationale is local recurrences tend to be primarily in and around the primary tumor site. So boost decreases the risk of marginal recurrence, and it is more advantageous when the margin unknown and in women less than 40 years. Benefit in elderly uncertain may omit. We usually give, most of the radiation oncology, they usually give boost in most of the cases, except in a very low risk patients or in a very elderly patient. So boost is given by EBRT, means external beam radiotherapy without any invasive technique, or by brachytherapy. In external beam radiotherapy, we are using photons and electrons, and brachytherapy, interstitial catheters and memocyte can be utilized. So the localization of lumpectomy cavity is very essential. So there are various techniques by CT, by MRI, ultrasound, even primary mammography or the surgical scar. They are of utmost importance, and they help in localizing the boost volume. And I think Professor Manoj Pandey sir has started localizing the tumor before giving neoadjuvant chemotherapy, because many a times patients receive neoadjuvant chemotherapy, has a very good response, get operated and followed by radiotherapy. So many a times it is difficult to localize the primary tumor volume or the area. So the localization by radioactive material, it will be really helpful. So the combination of surgical clips with a treatment planning CT with a pre-treatment imaging is most ideal. And CT of biopsy cavity or post-surgical changes in combination with the clinical information, including mammography, scar location, operative notes, patient input, and other information are very essential for the placement of the field and energy of the electron boost. So in EBRT, we are using electron beam for giving boost. It is very easy in setup, low dose to whole breast, good cosmetic result, low cost, and there is a decreased time required for planning. And the USP of electron beam is that it does not penetrate deep. It gives surface dose basically. So we can just measure the length, how much we need to give, and it is very easily planned and very easily delivered. So yeah. And if we are planning by photon boost, the planning will be similar to whole breast irradiation, but the field will be smaller. Many a times patients come with seroma which keep on increasing. So during and that will definitely, if the seroma is not, it increases. So during the treatment volume will change. So many a time what happens during whole breast radiotherapy, many a times we have to drain the seroma, match the field, and again maybe we need to, sometimes very less oftenly, but we need to replan the patient. But after 5 to 6 weeks of treatment, or if we are doing hypofractionation after 3 weeks of treatment, many a times the seroma, it becomes kind of constant, and so the treatment planning becomes much easier. So seroma, and we give margin of 1 centimeter to CTV, and then PTV 1 centimeter. So it is very localized. Interstitial boost can be also utilized to give boost to the cavity. In this 1 to 3 plane of needle may be needed to cover the PTV depending on the size. The needles are implanted and in most of the cases inserted in a medial-lateral direction. In a very in a medial or lateral location of the tumor size, needle should be implanted in a craniocaudal direction to enable separate the target area from the skin point. And it needs expertise and it has a learning curve. This is a clinical scenario. So till now the crux is if BCT is done, it has to be irradiated and a boost is needed in most of the patient except very elderly or low grade tumor. And there are a very small subset of the patient where we can omit radiation. These are very elderly patients with the good tumor characteristics. And yes. And then now the next clinical scenario is occult breast cancer. So if the patient comes with axillary lymph node and there is no breast mass, so the standard of treatment is ALND followed by whole breast radiotherapy. So the use of whole breast radiotherapy and axillary node clearance as a local regional treatment for patients with occult breast carcinoma, and management of the axilla does not differ from that of the patient with the breast cancer with clinically palpable axillary lymph node, which remains the gold standard. Now, RT for elderly patient, I have already explained. If you see this graph, the patients only on tamoxifen post surgery, and the patient only on RT followed by tamoxifen. So if we see it's after three to 4 years, the lines they are separating, means till 3 to 4 years the result is almost equivalent whether they are receiving or not the adjuvant radiotherapy, very elderly population. So definitely if the patient is very having comorbid conditions, poor renal function or any kind of comorbid condition, life expectancy is low, so there is no point of exposing her to additional treatment. So discuss RT with all the patient after BCS, and omission of RT is probably best reserved for women 70 to 80 with multiple comorbidities and if the life expectancy is less than 8 years. Now, post-mastectomy. Locoregional failure, the rationale is the locoregional failures occurs commonly in post-mastectomy chest walls, nodal basins, supraclavicular lymph node, axillary and internal memory region. Post-mastectomy RT not only eradicate occult disease from this region, thus reducing the locoregional control and thus reducing distant metastasis. Effective systemic therapy has been postulated to increase the likelihood of distant eradication of the disease. So recurrence risk will increase if there are any positive axillary lymph node. Initially, more than 4 axillary lymph node was an indication, but now any positive lymph node is an indication for post-op RT. And a tumor size more than 5 centimeter is an indication for post-op RT. And any high-risk feature, grade 3, LVSI, TNBC, ERPR, negative, triple negative, hormone negative malignancies with high-grade features, they should be subjected to post-op RT. So these are the recurrence rates. 50% of the recurrence occurs in chest wall, 20 to 40% of in SCF or ICF, less than 5% in axillary lymph nodes, and internal memory, very few clinical recurrences. So this is a schema after MRM, any T4, NEN or T3N plus, positive margin invasive disease, or any T with 4 then lymph nodes positive should undergo RT. Now initially, as I already mentioned, initially the indication was more than 4 lymph nodes, but now any lymph node positive, go ahead with RT, T3N0, DCIS at margin, and TNBC. These are the high risk criteria. So we should know when the RT is not needed. Any tumor less than 5 centimeter and lymph node negative, N0, and with good clinical, with good pathological features, the RT should be omitted. But in rest of all the cases, any T3, any N1 with high risk factors, even if the patient is having tumor 2 centimeter, medial quadrant, TNBC, RT should be, RT is advocated. Now coming to hypofractionation. So historically, we used to give 50 grain, 25 fraction for MRM and BCS with or without boost. That was a standard of practice for many years. And then recognizing the limitation in terms of convenience and cost, randomized trials in 1990 and 2000 investigated the moderate hypofractionation defined as daily doses of 2.65 to 3.3 gray could yield oncologic or cosmetic outcomes similar to conventional. And there were many trials, main were START A, START B trials, and they have supported the safety and efficacy of the moderate hypofractionation. And initially we used to give hypofractionation only after BCS, but now Astro has updated the guideline in 2018. We can give hypofractionation in all the patient of all the stage, of all the pathology, nodal status, in all the patients. After BCS, after mastectomy, hypofractionation can be done. So the treatment duration of 5 or 6 weeks has been reduced to 3 weeks or 4 weeks, depending on the boost. So this was the trial, START A and START B trial. They compared 50 grain, 25 fractions, 5 fractions per week. In START A, they had 2 arms, 41.6 grain, 13 fraction, and 39 grain, 13 fraction. The result was equivalent. And START B trial, 40 grain, 15 fraction. And it was seen that long-term follow-up confirms that hypofractionated radiotherapy is safe and effective for patients with early breast cancer. The results support the continuous use of 40 gray in 15 fractions. The overall survival and disease-free survival, the local regional recurrence, and the distant mets, the results are comparable. So the result of this study showed that the conventional fractionated radiotherapy and hypofractionated radiotherapy do not differ significantly with respect to efficacy or toxicity in post-mastectomy breast cancer. So this is the final outcome. There is no difference in outcome between conventional fractionation and hypofractionated in terms of efficacy when we evaluate local recurrence, local regional recurrence, distant recurrence, disease-free survival, and mortality. There is also no difference concerning the safety when we assess the occurrence of fibrosis, ischemia, and rift fractures. Hypofractionated show better results in relation to breast edema, telangiectasia, and acute skin radiation toxicity. And now Astro has recommended in 2018, like initially it was T1, T2, N0 hypofractionation should be done. But in 2018, any age, any stage, any chemotherapy taken, any size, anything, you can go ahead with hypofractionation. Now the studies are going on for extreme hypofractionation. So 5 weeks, from 5 weeks, we have reduced to 3 weeks. And now the studies are going to reduce the post-op RT of breast to just 1 week. So this is fast forward trial. And the 5-year efficacy, what they have done, they have compared 40 gray in 15 fraction with 27 gray in 5 fraction and 26 gray in 5 fraction, followed by sequential boost. And the result is 5-year ipsilateral breast tumor relapse incidence after 1 week course of radiotherapy delivered in 5 fraction is non-inferior to the standard 3-week schedule. The 26 gray dose level is similar to 40 gray in 15 fraction in terms of patient assessed normal tissue effect, clinician assessed normal tissue effect, and photographic change in the breast appearance. But It's just a single RCT, no meta-analysis, no long-term follow-up, no subgroup analysis, and very few centers have started. And we actually don't know the effect of such a high dose per fractions on underlying lung or heart. So definitely more mature data is awaited before we incorporate this into our clinical practice. Now coming to accelerated partial breast irradiation. So the rationale is 20 to 40% of the patient do not receive RT after breast conservation surgery due to logistic issues, and more than 70% of in-breast recurrences are near tumor bed. So partial breast irradiation, it has potential to control the tumor, increase the treatment compliance, and minimize the side effect. So this is done basically this is the inclusion criteria for considering the patient for APPI, because the concept is we have to treat only the tumor, the cavity, the post-op cavity. We are not going to address any lymph node area. So the tumor has to be of less than 2 centimeter T1 stage, and margin should be at least of 2 millimeter, and there should be no LVSI. Status should be positive, unicentric disease, age should be more than 60 years, no genetic BRCA, BRCA2 positive, they should be negative, and there should be this extensive intraductal component is not allowed. So it is a very stringent criteria. Very small subset of the patient with less than 2 centimeter tumor with no lymph node are actually the right candidate for APPI. And these are the cautionary group. Before considering this patient, definitely the discussion is needed. Age 50 to 59, tumor size 2 to 3 centimeter, and margin close less than 2 millimeter, and ER status negative. So these are the caution points. So these for the subset of the patient who are unsuitable for ABPI are any tumor more than 3 centimeter T4 N plus, definitely, because we have to irradiate entire breast and regional lymph node depending on the lymph node status. Any genetic inherited factor, high grade extensive LVSI, extensive intraductal component, any multifocal disease, it is definitely contraindication to BCS as well. We don't do BCS in multifocal disease. Margin positive, definitely no. And if the patient has received neoadjuvant chemotherapy, because when we'll get the patient, definitely that will be downstage, so no point of considering for APPI. So these are the various techniques for delivering APPI. Interstitial brachytherapy, where the needles in 3 to 4 planes are put in the lumpectomy cavity, and then dose of about 3.4 gray per fraction. It can be given twice a day, separated by 6 hours, and given in 10 fractions. So this can be done, and this is most commonly practiced form of ABPI. This is the dosimetry. Then memocyte placement, it is a single catheter balloon applicator where the balloon is inserted in the lumpectomy cavity. It is inflated with the saline solution mixed with a small amount of contrast to aid visualization, and it is inflated to a size that would completely fill the lumpectomy cavity. And then iridium source is connected, and it goes, and the dose is prescribed at the point at least 0.5 centimeter from the skin surface. And this is intra-op radiation, in which once the patient has been operated, the probe, it gets into the lumpectomy cavity and it's delivered the dose. But the biggest disadvantage is we don't know the final histopathology of the disease. External beam radiotherapy. In this also, we give around 34 to 38 gray in 10 fractions, and it is most commonly practiced. So these are the various types of the various modalities by which APPI can be delivered. 3D CRT, and it has a high potential for widespread use because it can be done by any linear accelerator, and it is suitable for almost all the cases. And but the sparing of the normal breast or other organ is less, because the concept is the beam will go from one place to one side and will exit from other side. So definitely there will be dose to the normal tissue, adjacent normal tissue, maybe lung, and maybe to the heart also. So yes, it has dose spillage. Interstitial brachytherapy, high level of expertise is required, and it is fairly very frequently being used. And Mammocyte also, it is also it's not suitable for a large or irregular cavity, because the balloon will not. Drawback is cavity shape and size, also easy to use, but the QA is very stringent. And others are intraoperative, and they have very limited scope of use because of the infrastructure. But they will definitely deliver a very high dose, because the best time to irradiate is during the time of surgery, theoretically. But definitely we don't know the histopathology report at that point of time. So now coming to IMRT versus conventional techniques. So why to prefer IMRT? So IMRT definitely has a dosimetric advantages, better dose homogeneity for entire breast, better coverage of the tumor cavity, and feasibility of simultaneous integrated boost. And yeah. So this IMRT we basically do by photon. Now the proton is also coming in picture. So proton is basically a particle. So the main feature of any particle, because proton is most commonly now being used. So the most important feature is when we treat by photon, the dose will go, the beam will go from one side, and there will be exit dose, okay, and there will be spillage also. But the beauty of proton or particle therapy is there is no exit dose. The dose will be entirely decimated in the target volume, and there will be no exit dose. So very beautifully we can protect the cardiac dose, the lung dose will be minimized. So, but right now there is no RCT to compare and to assess whether the proton therapy will actually reduce the risk of cardiovascular mortality or morbidity or not. And secondly, it is a very expensive treatment. So definitely we have to weigh the benefit and cost factor as well. And proton therapy as of now for breast, it is not the standard of choice, because of the lack of the studies, and also because we are getting fairly good result with other radiation techniques. So definitely we have to look at the cost as well. The proton may be useful for advanced disease if there is internal memory lymph node involvement, if the patient has already received cardiotoxic chemo and there is high risk of cardiotoxicity, young age patient, and poor cardiac anatomy, left medial tumors, any pre-existing cardiac disease, decrease arm mobility, because for the treatment by photon we need specific arm position for the better delivery of the radiation. So now coming to breast reconstruction, if you see, this is a European data. Breast reconstruction has increased from 14.8% in 2000 to 31.9% in 2011. And recent data I was not having regarding the increase in practices. So if you see the the timing of the delivery of radiation, so it can be delivered there are three techniques. First is immediate reconstruction, like mastectomy has been done and immediately reconstruction has been done. Then radiation can be given as usual, like a adjuvant treatment. Delayed reconstruction is mastectomy has been done and then the radiation is given, and followed by reconstruction within 6 to 12 months, preferably more than 16 months and less than 12 months. The third is delayed and immediate reconstruction. In this, mastectomy has been done and tissue expander is placed between the skin flap, skin pocket and pectoralis muscle, or between pectoralis muscle and the chest wall. And this expander has a metallic probe by which the saline is infused, and that the patient has to come weekly or fortnightly for the infusion. So if the patient needs RT can be delivered with a tissue expander in situ, followed by after 2 weeks, again the tissue expansion can be done. And after that's definitely, I'm not expert, that's a surgeon, plastic surgeon discretion when to replace the tissue expander with the permanent implant. Now, implant can be of two types: autologous implant and autologous breast reconstruction and synthetic implant. Initially, it was thought that autologous breast reconstruction will not tolerate RT, and this was result of initial data. But now the data has come, autologous breast reconstruction, they are tolerating RT better as compared to implants, because many a times implants, not many a times, less frequently, the implant may have capsular rupture or contracture post RT. So what has to be done, I mean, what type of implant, that is plastic surgeon's discretion. But radiation can be done before reconstruction also and after reconstruction also. And if done after, and I have discussed with many radiation oncologists, because there is no head-on comparison, but there are people who are regularly treating after reconstruction, and they have found that there is no side effect, no complications, severe complication if we deliver radiation after reconstruction. And even if we are delivering, if the reconstruction is done after RT, there is no much, the failure rate is not much high. So yeah. So radiotherapy can successfully incorporate it into the treatment plan in women who choose immediate reconstruction, regardless of whether an autologous or implant-based approach. Autologous tissue might tolerate post-mastectomy radiotherapy better than previously believed, leading to high satisfaction and cosmetic outcome. And heterogeneously in delivery of radiotherapy, including modality, fractionation, use of bolus, boost, and difference in nodal target volume could affect the reconstruction outcome. Implant reconstruction has high risk of long-term complication following post-mastectomy radiotherapy than autologous, definitely because of the contracture or capsular rupture. But technically, and if we see the graph, more and more patients are now opting for implant rather than autologous.
Dr. Ankita, would you please conclude?
Yes, sir. Post-treatment lymphedema. This is the major morbidity with the patient usually suffers after the combination of, after the surgery and radiotherapy. And it has been seen that if axillary lymph node dissection has been done, the lymphedema rate is approximately 20 to 23%. And if the RT, if we see only RT, then it's 11%. But if ALND and RT has been done, it is 40%. So it is not 23 plus 11, but it is 40%. So it is quite high. So rehabilitation plays an important role. And before moving the slides, I would like to say that now sentinel lymph node biopsy is commonly practiced to reduce the morbidity due to axillary lymph node dissection. And also, if the adequate axillary lymph node dissection has been done, post-op RT to axilla is usually avoided in most of the centers. So that is how we can reduce the morbidity, because the axillary recurrence, as we have seen, is less than 5%. And if the patient has to recur, definitely she will recur, she will be recurring at a distant site. So this is sequel of post-treatment sequel, basically related to lymphedema. And now we have a very competent rehabilitation department with us, and they are doing combined decongestive therapy with lymphatic exercises, manual lymphatic drainage, and multi-layer lymphedema bandaging. And we are all our patients, they start their rehabilitation prior to starting RT, and they continue during the RT and definitely post RT also. So they are having good results and they are quite satisfied. And let's see what's the long-term results. So the take-home message is RT remains standard in most of the breast cancer. More tailored radiation treatment are needed in era of personalized medicine with a great attention to quality of life aspects. Modern RT technique has shown to be able to increase the homogeneity of dose distribution in target and to reduce the dose to OAR. Using these technique, RT will improve effectiveness and reduce side effects. These characteristics allow to face the new challenges of breast RT in hyperfractionation, locoregional treatment, and breast reconstructions and other special cases. And biologically driven indication will ensure in future a real tailored RT treatment to breast cancer patients. And the studies are going on because we have not the treatment is not yet based on the type tumor biology depending on luminal A, B. But the studies are going on. Maybe in near future, there are scopes that the treatment may be tailored according to the tumor biology. Thank you.
Thank you, Dr. Ankita. You have tried to cover a very vast topic of breast radiation and rehabilitation in a very short time. And it has been very beautifully done.
Thank you, sir.
The topic is open for discussion.
Ankita, you did a great job. In a period of 15 minutes, you could almost cover about 130 slides. I was just checking that. Yeah.
Thank you, sir.
In your first slide, you said that breast cancer is a systemic.
Yes, sir.
I'm not sure that statement, how much that is correct. You know, initially we had the Hofstadian concept, then Fisherian concept, but now there's a concept of the what is called the spectrum concept, which is there. And that doesn't say it's a systemic disease. It's in fact both. It's a systemic disease as well as also it's a stepwise progression, which is there. So now the breast cancer is considered as a mixed type of the thing rather than just saying it is a systemic disease. Okay. Just wanted to know from you that what is the sequence of giving the radiotherapy after you have done either the MRM or you have done the breast conservation surgery. And the patient has to also need the chemotherapy also. So in what will the sequence of that?
So usually it is post-systemic therapy radiation. So usually we finish the chemotherapy thing followed by radiotherapy. So we don't follow that formula that post-surgery within 4 to 6 weeks, we have to start the radiotherapy. In case of breast, suppose we are giving NACT, usually we follow AC followed by taxane. Now, whatever we are following, we first complete it, then go ahead with surgery, or surgery can be done in between the treatment, systemic chemotherapy if the patient is not tolerating, and followed by radiotherapy. Means we usually complete chemotherapy and then go ahead with radiotherapy.
So after finishing all the cycles of chemotherapy,
yes, sir,
then you will give the radiotherapy, both setting BCS as well as the MRM?
Sir, in BCS, yes, sir.
Yes, in both the settings.
Yes, sir.
In both the settings.
Both the settings.
And except if the patient is HER2 enriched and is being treated with trastuzumab, where radiation can be given with trastuzumab.
Yes, sir. So can I add it at some point, sir? So if you are adding trastuzumab, so first we give 4 cycles of AC followed by taxane, and along with taxane we start trastuzumab. So trastuzumab is usually given for 17 cycles for almost 1 year. So that is along with radiation. So usually patient gets 1 or 2 cycles during the course of radiotherapy.
I would like to add something. Just to say, it's a comment like if the patient has been undergone post-mastectomy radiotherapy and there is like close margin or something like that, then we would like to give radiotherapy upfront followed by the adjuvant chemotherapy. Now regarding the BCS setting, I think the protocol is to complete the radiotherapy first in order to take care of the locoregional disease, like microscopic disease which have been there, for which we give the radiotherapy. So in BCS setting, radiotherapy needs to be done first, and then we sequentially follow it by chemotherapy and the targeted therapy. So this is like my comment on it. I need
No,
you.
this is not a recommendation, because
Yes, sir.
you
Yes.
survival is determined by the distant spread, not by the local recurrence. So you have to take care of the micrometastasis first before you complete your local treatment.
I
That is the
have to
current
add,
recommendation.
can I say, I have to add a comment. If the patient is coming with positive margin, I think we should send patient for, for revision of the margin uh, before
That's true. Fully
doing
agree. If the margin
radiotherapy.
is positive, the cavity re-excision has to be done.
Yeah. And
No, I was
NCCN
talking
also
about the
says
close.
post-systemic therapy or emission radiation should be post-systemic.
Post-systemic.
Yes.
That is the recommendation.
Yes.
Dr. It was an excellent presentation. I wanted to know what was the long-term result of the lymphedema management with the decongestant therapy and the pressure garments, long-term.
So long term, sir, I have not read it. I mean, I have not evaluated, and definitely I'll get back to it and I'll reply you then for the precise answer. But definitely,
Actually,
the rates has decreased clinically. What we are seeing in our clinics, and many patients they are coming with lymphedema, gross lymphedema, even after 4 or 5 years of treatment. It happens, it's usual, and clinically they are getting very good response. But the only thing, the patient has to travel daily, come daily for 20 to 30 sessions. So that is the logistic issue. Otherwise, clinically the patient are having a good response. Long term, I'm not very sure because I have not read it.
actually, what we are recommending is a
Yes.
free lymph node transfer or a lymphatico venous anastomosis. So this gives a more of a permanent results. What we are thinking of that,
Okay.
because this type of surgeries, lymph node transfer is one of the answers to it.
Sir, are you
Anyway, it
doing
was
it?
an excellent. Yeah, we have done only one, and the
Okay.
result is good. Only
Okay.
Sir, the most important
good.
thing in management of breast cancer is to prevent lymphedema from developing.
Yes.
And there are certain steps or precautions that a surgeon has to take while doing the surgery. Then there are certain steps and precautions that a radiotherapist has to take while delivering the radiotherapy. And all the time from day one, the disease is diagnosed, patient has to be put into a exercise rehabilitative program where the patient has to continue doing it, not only till the end of the treatment, but even afterwards. So the most important thing in breast cancer treatment is to prevent development of lymphedema.
Sir, when we were not having rehabilitation department, we used to strictly instruct all the patients, other exercise they were doing, other than that, all the basic instructions to take care of the treated hand, not to use, not to lift heavy weights more than 5 kg, not to very rigorously use that hand. And whenever they are sitting, they have to raise it, putting the pillow under arms so that the arm is in upside down position. Whenever they are doing massage, they have to do from like hand to upward so that the passive drainage of the lymphatics can happen. So these were the minor instruction we used to very meticulously explain the patient. This along with the exercises.
I think one of the very important things for the lymphedema, whatever you do for these patients, that these patients has to be kept on the long-term antibiotics. Just like in the filarial lymphadenitis, we are carrying out that the patient is kept on the Panidor injection. So the same thing has to be done here because these patients are likely to have the dermatolymphadenitis, which is there. And because everything is obstructed at the axilla, so there will be definitely the patient with the dermatolymphadenitis. And these patients should be kept on the Panidor injection almost for the lifelong.
Thank you, sir.
Any other questions?
I think we should move to the concluding remarks by Dr. A.K. Kaushik, I think. Is it okay? So we should move that.
Yeah, sure, sir. Definitely.
So First of all, I would like to thank Apex Hospital family, especially our own SK Singh boss. Hello. Hello, I'm audible.
Yes, sir. Yes, sir.
Yeah, आ रही है आवाज
Okay,
आपकी,
Dr.
बोलते
Ankita.
रहिए.
So, I like to thank whole Apex family, especially Dr. SK Singh boss and Ankita, who are managing such educative and informative webinars on regular basis. Last time we had a webinar that was really very informative and at the national level. This time also we have this webinar in a fantastic way. We are covering almost all the topics related to cancer, especially head, neck, and breast. Dr. Deepak delivered a very good lecture, and especially in oncology, when you are operating on head, neck, and breast, the cosmetics matters a lot along with the treatment part, and that was well covered. And Apex is doing it. That is a happy moment. Dr. Sujit Verma, he talked good about the interventional radiology related to trauma patients, and that was a very good session. And Dr. Ankita, of course, is well known for her speech delivery and clarity. So Ankita spoke so well, and it was a very good discussion having on the behalf of Surgical Society and Apex family. And we hope we will have good such seminars from Apex Hospital and related hospitals to have Surgical Society having good group of people discussing informatics and latest developments in surgical practice in regularly. So finally, I thank moderators, none other than Dr. Manoj Pandey, who happens to be my classmate and roommate, along with the heading the department of Oncology in Varanasi University. Sharing knowledge with him is always pleasant. And Dr. Sudhir Kumar, our own president of Varanasi Surgical Society, is very active always on all the talks and educative programs. I could see Professor Khanna also, sir, he's the revered guru and the best academician. So overall, it was a very pleasant moment for me to deliver a vote of thanks amongst our own people who have performed so well in their academics. So again, I thank all of you for having a good academic session. Thank you.
Thank you, sir.
Thank you, everyone.
Thanks to everyone.
Thank you, everyone. Kamlesh, you have concluding remarks?
Yes, sir. I'm thankful to Varanasi Surgical Society for helping us a lot in order to organize this excellent webinar, which has been concluded or which has been completed in the leadership of Dr. Sudhir Kumar Singh, in your honorable presence, as well as with the help of Dr. A.K. Kaushik, sir. There were so many eminent personalities from Surgical Society who has participated in this program, and we thank them all for cooperating us and participating in this webinar on advances in surgery. Thank you very much, sir. We need your cooperation and means further also, and your encouragement will help us to organize even better programs than this, better educational programs than this in coming future also. Thank you, sir. Thank you very much. Thank you, everyone.
Thank you, everyone. Have a good night.
Thank you.